Welcome to Night Shift Pulse. Comment your city and the time below. The night connects us all. If you enjoy what you hear, please subscribe. Let's step into the dark. Story 1. The Vascular Surgeon's Unscheduled Clamp. I was 3 years post-fellowship when the clamp appeared. Not appeared in the dramatic sense, it was simply there, among the instruments on the Mayo stand, its jaws clean and its ratchet mechanism firm. Lori, my scrub nurse, had laid out the standard tray for an emergency femoral embolectomy. I had not asked for anything unusual. The patient, a man in his late 60s with acute limb ischemia, was draped and prepped. The anesthesiologist had achieved stable sedation. I made my incision at 23 minutes past midnight, exposing the femoral artery with practiced efficiency. Everything proceeded as expected until I encountered the branch vessel. Vascular surgery operates within narrow tolerances. Blood flow is measured in milliliters per second. Clamp placement is deliberate. I had reviewed the preoperative CT angiography twice. The imaging showed a single thrombus lodged in the superficial femoral artery, straightforward for retrieval. There was no notation of collateral compromise or branch involvement. Yet when I retracted the tissue, I found a smaller vessel, likely a variant profunda branch, engorged and fragile, its wall distended in a way that suggested imminent rupture. I called for a microvascular clamp. Lori hesitated. She gestured to the tray. There, beside the standard bulldog clamps, lay a smaller instrument I had not seen before. Its design was precise. Slender jaws, a curved profile suited for deep access, and a tension spring calibrated for delicate vessels. I lifted it. The weight felt correct. The surface showed no oxidation, no wear. I applied it to the branch vessel. The jaws closed with a soft click. The distension stabilized immediately. The embolectomy proceeded without incident. I retrieved the thrombus using a Fogarty catheter, confirmed flow restoration with Doppler, and closed in layers. The patient's distal pulses returned strong and regular. I dictated my operative note at 2:14 in the morning, describing the procedure as routine. I did not mention the clamp. It seemed unnecessary. Lori had already packed the instruments for sterilization. I assumed she had included it as a precaution, though I had not discussed variant anatomy with her before the case. 2 days later, I reviewed the patient's post-operative course. Recovery was unremarkable. The leg remained viable, perfusion indices normal. I signed off on the discharge summary and moved to the next case. It was only when I returned to the operative logs, compiling data for a quarterly review, that I noticed the discrepancy. The instrument list for that night's embolectomy included the microvascular clamp by name. Dietrich microbranch clamp, 7 centimeters curved. It was cataloged as part of the standard vascular tray. I did not recognize the name. I walked down to the surgical supply office and asked the coordinator, a woman named Gwen who had managed inventory for 15 years. She pulled up the database. The Dietrich clamp had been part of the hospital's vascular inventory since 2009. It was listed as a recommended instrument for cases involving profunda femoris variants. The entry included a reference to a protocol update that year, citing improved outcomes in emergent lower extremity revascularization. I asked Gwen if she recalled the update. She did not. She showed me the procurement records. The clamps had been ordered in a batch of 12. All were accounted for. All had been in rotation for over a decade. I completed my fellowship in 2014. I trained at a different institution. I had never encountered a Dietrich clamp during my residency or in any of the visiting rotations I completed. When I joined this hospital, I inherited the vascular service's standard protocols. No one mentioned specialized microclamps. No one reviewed the inventory with me in detail. I had simply used what was available, trusting that the trays reflected current best practices. I returned to the operative footage. Our facility records all procedures for education and liability purposes. I requested the video from the night of the embolectomy. The timestamp began at midnight 19, 2 minutes before my initial incision. The camera angle mounted above the surgical field captured the Mayo stand in partial view. I watched Lori arrange the instruments. Her movements were methodical. She placed the standard clamps first, then the retractors, then the suction tips. At midnight 22, she paused. Her hand moved to a compartment in the instrument cart that I could not see clearly in the frame. She withdrew the Dietrich clamp and set it on the tray. She did not hesitate. She did not check a list. She simply placed it as though it had always belonged there. I froze the video. I studied the instrument under magnification. The design was consistent with what I remembered: the slender jaws, the curved profile, the spring mechanism. I resumed playback. At midnight 41, I reached for the clamp. My hand moved without hesitation as though I had used that instrument many times before. I applied it to the branch vessel. The jaws closed. The vessel stabilized. I continued the procedure. I contacted the manufacturer, a medical device company based in Pennsylvania. I provided the model number from the inventory database. The representative confirmed that the Dietrich clamp had been introduced in 2009 as part of a limited initiative to address variant vascular anatomy in emergency settings. The initiative had been based on a study involving 12 hospitals. Ours was listed as a participating site. The study's findings had supported the clamp's inclusion in standard protocols. I asked for a copy of the study. The representative sent it within an hour. I read the document that evening in my office. The study detailed 68 cases of femoral embolectomy complicated by profunda branch involvement. In 41 cases, surgeons had used improvised techniques, standard clamps, temporary sutures, or manual compression, resulting in a 15% rate of iatrogenic injury. In 27 cases, the Dietrich clamp had been employed. The injury rate in those cases was 0. The conclusion recommended adoption of the clamp as a preventive measure. The study's lead author was listed as a vascular surgeon at our institution. The name was unfamiliar. I checked the hospital's faculty directory. No such surgeon appeared in the records. I searched the archives. The surgeon's personnel file had been transferred to off-site storage. I submitted a retrieval request. It took 3 days. When the file arrived, I found a standard employment record. Hire date in 2006, departure in 2012. The surgeon had completed a fellowship in vascular surgery and had worked exclusively in emergency and trauma cases. The file included a photograph. I studied the face. I did not recognize it. The surgeon's operative logs were attached. I scanned the entries. In 2009, the surgeon had performed 18 femoral embolectomies. 12 involved profunda branch complications. All 12 used the Dietrich clamp. The outcomes were documented as optimal. I cross-referenced the dates with my own surgical history. I had not been practicing in 2009. I was still completing my residency in another state. I had no connection to this hospital or its protocols at that time. Yet the study's data had shaped the inventory I inherited. The clamp I had used without question had been introduced based on cases I had never seen, performed by a surgeon I had never met. I returned to the video of my own case. I watched my hand select the clamp. I watched the instrument stabilize the vessel. I watched the procedure conclude successfully. I could not identify the moment when I had learned to use that tool. I could not recall a training session, a lecture, or a demonstration. The movement had felt automatic, as though the knowledge had always been present, waiting for the precise situation that required it. Lori retired 4 months later. I attended her farewell reception in the staff lounge. I asked her casually if she remembered the night of the femoral embolectomy, the case with the branch vessel. She smiled. She said she remembered. She said it had been a good case. I asked her about the clamp. She looked at me, her expression calm. She said it had been on the preference card. She said it had always been on the preference card. I thanked her. I did not press further. I still perform femoral embolectomies. I still encounter profunda branch variants. The Dietrich clamp is always available. It is always placed on the tray without discussion. I use it when necessary. The outcomes are always optimal. I no longer review the footage. I no longer question the inventory. But sometimes when I dictate an operative note, I pause before describing the instruments. I consider whether to list the clamp by name or to omit it, calling the technique standard. I consider whether the distinction matters. The records will reconcile either way. The protocol will remain in place. The next surgeon will inherit the same tray, the same tools, the same knowledge that feels both learned and intrinsic. Some instruments become standard not because we chose them, but because the cases that required them have already been performed. Story 2. The Orthopedic Surgeon and the Bone Inventory Ledger. Orthopedic surgery is an exercise in logistics. Every screw, every plate, every stem and socket is tracked from manufacturer to patient. The supply chain operates on redundancy and verification. I learned this during residency, where a single missing serial number could delay a case for hours. By the time I began practicing independently, inventory management had become second nature. I trusted the system because the system was designed to be trustworthy. It reconciled every component every time. The case that disrupted this certainty was a routine total knee arthroplasty. The patient was a woman in her early 70s with advanced osteoarthritis. Preoperative planning had been thorough. I had selected a posterior stabilized implant system, templated the sizing from her radiographs, and confirmed availability with the surgical supply coordinator 3 days in advance. The implants, femoral component, tibial tray, polyethylene insert, and patellar button, were standard inventory. The serial numbers were logged in the electronic health record. The components were sterilized and ready. I began the procedure at 7:45 in the morning. The anesthesiologist had achieved spinal anesthesia. The patient was positioned supine with a tourniquet applied to the thigh. I made a midline incision, reflected the quadriceps, and exposed the joint. The arthritic surfaces were worse than the imaging suggested. The medial femoral condyle showed full-thickness cartilage loss with subchondral sclerosis. The tibial plateau was similarly degraded. I proceeded with the bone cuts, using the alignment guides to establish proper mechanical axis. The resection was precise. I trialed the components. The fit was adequate, but I noted slight gapping in the flexion space, common in cases with ligamentous laxity. I asked the scrub tech, a man named Aaron, to confirm the implant sizes. He checked the trays. The femoral component was size 3, the tibial tray size 4, the polyethylene insert 10 millimeters. All matched the preoperative plan. I prepared to cement the definitive components. Aaron opened the sterile packaging and placed the implants on the back table. I inspected each piece. The femoral component appeared slightly different in contour than the trial. The anterior flange was more pronounced. I assumed it was a manufacturing variation within tolerance. I proceeded with cementation. The femoral component seated perfectly. The tibial component followed. I inserted the polyethylene and reduced the patella. The joint moved through a full range of motion without binding. I checked the alignment with a mechanical axis guide. It was neutral. I irrigated the wound, released the tourniquet, and achieved hemostasis. The closure was routine. The entire procedure lasted 2 hours and 11 minutes. I dictated the operative note in the recovery area. I listed the implant sizes and serial numbers as recorded in the system. The patient's post-operative course was unremarkable. She began physical therapy on the first day and was discharged on the third. At her 2-week follow-up, the incision was healing well. Her pain was manageable. Her range of motion was progressing on schedule. It was 6 weeks later, during a quarterly audit, that the discrepancy emerged. The hospital's compliance officer, a woman named Rita, contacted me by email. She explained that the orthopedic service was undergoing a routine inventory reconciliation. One of my cases had been flagged. The implant serial numbers listed in the operative note did not match the serial numbers in the supply chain database. Specifically, the femoral component I had documented had no corresponding procurement record. It had not been ordered. It had not been shipped. It had not been logged into inventory. I reviewed my own records. The serial number in my operative note was correct. I had transcribed it from the packaging. I called Aaron. He confirmed that he had scanned the barcode on the femoral component's sterile tray before opening it. The scan had registered in the system without error. Yet, according to the supply chain database, that serial number did not exist. It had never been assigned by the manufacturer. Rita scheduled a meeting. I brought the printed surgical logs, the implant specifications, and the barcode scan records. She brought the supply chain audit and a representative from the manufacturer, a man named Colin who managed the regional distribution network. We sat in a windowless conference room and reviewed the data on a wall-mounted screen. Colin confirmed that the serial number in question had never been issued. The manufacturer's database showed no record of that component being produced. He explained that each implant received a unique identifier at the point of fabrication. The identifier was linked to quality control data, sterilization batch numbers, and shipping manifests. The absence of a record was not just unusual, it was, in his words, impossible. I asked Colin to check whether the serial number might have been misread or transposed. He entered variations into the database. None returned a match. I asked whether the component could have been part of a research batch or a product line I was unfamiliar with. He said no. The design I described, particularly the pronounced anterior flange, matched a prototype that had been tested 5 years earlier but never brought to market. The prototype had been discontinued due to concerns about overconstraint in certain patient populations. Rita asked if I had any documentation beyond the operative note. I did not. The implant packaging had been discarded per standard biohazard protocol. The patient's post-operative radiographs, however, were available. Rita pulled them up on the screen. The femoral component was clearly visible. Colin leaned forward. He studied the image for several seconds. He asked if he could forward it to the manufacturer's design team. I agreed. The response came 2 days later. The design team confirmed that the component in the radiograph matched the discontinued prototype. They noted the anterior flange geometry and the specific curvature of the trochlear groove. They also noted that the prototype had been used in only 12 cases, all conducted at a single research hospital in the Midwest. Our hospital had not been a research site. We had no access to prototype implants, yet the component was unmistakably present in my patient's knee. Rita expanded the audit. She requested records for all orthopedic cases I had performed in the previous year. She cross-referenced the serial numbers with the supply chain database. 3 additional cases were flagged. In each instance, a component had been used that had no procurement record. In 2 cases, the components were standard models with unassigned serial numbers. In the 3rd case, the component was another prototype, a tibial tray with an experimental keel design that had never been released. I did not remember selecting prototype components. I did not remember any deviation from standard inventory. I remembered only the trays Aaron prepared, the implants he handed me, and the successful outcomes that followed. I requested the operative footage for the flagged cases. Rita provided access. I watched the first video in my office late one evening. The case was a total hip arthroplasty. The timestamp showed the procedure beginning at 8:03 in the morning. I watched Aaron open the sterile packaging for the femoral stem. I watched him place it on the back table. The component appeared identical to the standard stem I had ordered. I watched myself inspect it, position it in the femoral canal, and impact it into place. The fit was excellent. The stability was optimal. The procedure concluded without complication. I paused the video and examined the component in freeze frame. I could not identify any feature that distinguished it from the expected implant. I resumed playback and watched the remainder of the case. At no point did I question the component. At no point did Aaron indicate any irregularity. The system had behaved as though everything was in order. I watched the second video, then the third. The pattern was consistent. In each case, the implants appeared standard. In each case, the procedures succeeded. In each case, the serial numbers recorded in the operative notes corresponded to components that, according to the supply chain database, did not exist. Rita scheduled a follow-up meeting. She brought Colin again, along with a hospital administrator and a representative from the legal department. The tone was measured but serious. Colin explained that the manufacturer had conducted an internal investigation. They had reviewed production logs, shipping records, and distributor inventories. They had found no evidence of unauthorized implant releases. They had found no gaps in the chain of custody. The components I had used simply did not exist within their system. The legal representative asked if I had any relationship with third-party suppliers or gray market distributors. I did not. I had never ordered implants outside the hospital's contracted vendors. The administrator asked if I had any explanation for how the components had entered the operating room. I did not. Rita proposed a solution. She suggested reviewing the surgical trays in real time before the next scheduled case to confirm that the components matched the procurement records. I agreed. The following week, I had a total knee arthroplasty scheduled. Rita and Colin attended the case. They stood in the operating room, masked and gowned, observing as Aaron prepared the trays. Aaron scanned the barcodes, each scan registered in the system. Colin checked the serial numbers against his database. All matched. The components were verified. I proceeded with the surgery. The knee resection was standard. The trialing was routine. I cemented the components. The alignment was correct. The range of motion was full. I closed the wound and dictated the note. Rita and Colin reviewed the records immediately after the case. The serial numbers I documented matched the serial numbers Colin had verified. The supply chain was intact. The case was compliant. Rita seemed relieved. Colin seemed satisfied. I thanked them for their diligence. It was 3 weeks later that the patient returned for follow-up. The incision had healed. The pain was minimal. The radiographs showed excellent component positioning. I documented the visit and closed the chart. That evening, I received an email from Rita. She had completed the final audit reconciliation. The case we had observed, the case that had been verified in real time, had been flagged. The tibial component's serial number, which Colin had confirmed before the procedure, no longer existed in the manufacturer's database. I called Colin. He confirmed that the serial number had been valid at the time of the case. He confirmed that he had personally checked it. He could not explain why it was now absent from the system. He suggested a database error. He said he would investigate. I did not hear from him again. I continued performing joint replacements. The components continued to arrive. The trays continued to be prepared. The serial numbers continued to reconcile in the moment, even when the records later suggested they should not have. The patients continued to recover without complication. The outcomes remained optimal. I stopped reviewing the inventory audits. I stopped requesting explanations. The system functioned as long as I did not question it. The ledger balanced as long as I did not examine the entries too closely. Some supply chains are built on trust. Others are built on the assumption that the components were always meant to be there, even when no one can remember ordering them. Story 3: The Pediatric Surgeon's Consent Form. Pediatric surgery requires precision and more than technique. Consent is a process, not a signature. Parents arrive frightened, confused, burdened by a child's diagnosis they do not fully understand. My role extends beyond the operating room. I explain the procedure in language stripped of jargon. I describe risks in terms that are honest but not cruel. I answer questions until there are no more questions. Only then do I present the consent form. Only then do I witness the signature. This process is not negotiable. It protects the child, the family, and the integrity of the procedure. The case that violated this sequence was an inguinal hernia repair in a 4-year-old boy. The diagnosis was straightforward. The hernia was reducible, not strangulated, and the surgical plan was standard. Open repair with mesh reinforcement if necessary. The boy's mother had been referred by his pediatrician. She had called the office 3 days before the scheduled surgery to ask questions. My nurse, a woman named Monica, had spoken with her for 20 minutes. The mother had seemed reassured but requested a final conversation with me on the morning of the procedure. I arrived at the surgical center at 6:30 in the morning. The boy was scheduled as the first case at 7:15. I expected to meet the mother in the preoperative area, review the consent form, and answer any remaining questions. Monica met me at the nurse's station. She handed me the boy's chart. The consent form was already inside, signed and dated. I paused. I asked Monica when the mother had signed it. Monica checked the timestamp on the form. It had been signed at 6:48 that morning, 18 minutes earlier. I asked where the mother was now. Monica gestured toward the preoperative bay. I walked over. The boy was lying on a gurney, dressed in a surgical gown, his mother seated beside him. She looked tired but calm. I introduced myself. She smiled. She said she was ready. She thanked me for taking the case. I explained that I wanted to review the consent form with her before we proceeded. She nodded. I asked if anyone had gone over the procedure with her in detail. She said yes. She said a surgeon had spoken with her earlier that morning. She said he had been thorough. She said he had answered all her questions. I asked who the surgeon was. She hesitated. She said she did not remember his name. She said he had been kind. She said he had explained everything clearly. She said she felt comfortable proceeding. I opened the chart and examined the consent form. The signature was legible. The date and time were correct. The form listed the procedure, the risks, and the alternatives. It was complete. Yet I had not spoken with the mother. No other surgeon was assigned to the case. I was the attending. I was the only surgeon scheduled in that operating room. I asked Monica if another surgeon had been in the preoperative area that morning. She said no. She said I was the first to arrive. I asked if anyone else had met with the mother. Monica checked the electronic log. The mother and son had checked in at 6:32. They had been escorted to the bay at 6:38. The consent form had been scanned into the system at 6:50. No other staff had documented contact with the family during that window. I returned to the mother. I asked her to describe the surgeon who had spoken with her. She said he was tall with dark hair graying at the temples. She said he wore blue scrubs and a white coat. She said he had seemed experienced. I did not match that description. My hair is light brown. I am average height. I had not yet changed into scrubs. I asked if the surgeon had introduced himself by name. She thought for a moment. She said he might have, but she could not recall. She apologized. She said she had been focused on her son. I could have delayed the procedure. I could have refused to operate until the discrepancy was resolved. But the boy was calm. The mother was comfortable. The consent form was signed and legally sufficient. I made the decision to proceed. I informed the anesthesiologist. We brought the boy into the operating room at 7:13. The procedure was uncomplicated. I made a small incision in the right groin, identified the hernia sac, reduced the contents, and ligated the sac at the internal ring. No mesh was required. The repair was tension-free. I closed in layers and applied a sterile dressing. The boy was extubated in the operating room and transferred to recovery. He was awake and comfortable within 15 minutes. His mother was allowed to see him shortly after. She held his hand and smiled. She thanked me again. I completed the operative note and returned to the preoperative area. I found Monica and asked her to print a copy of the consent form. She did. I took it to my office and examined it under the desk lamp. The signature was written in black ink. The handwriting was cursive, slightly slanted to the right. The loops were large. The baseline was uneven. I compared it to my own signature on a separate document. The slant was similar. The loop structure was similar. The unevenness was similar. I did not want to believe the resemblance was significant. Handwriting varies with pressure, speed, and tool. A mother signing under stress might produce marks that loosely resembled another person's script. I set the forms aside and returned to my clinical duties. I saw 2 post-operative patients in the afternoon. I reviewed imaging for a case scheduled the following week. I went home at 6:30 in the evening. That night, I could not stop thinking about the consent form. I retrieved a box from my closet containing documents from my residency, evaluations, case logs, letters of recommendation. At the bottom of the box, I found a procedural competency checklist from my 2nd year of training. It included a section where I had signed my name multiple times, confirming completion of supervised cases. I spread the papers on the kitchen table. I compared the signatures to the mother's signature on the consent form. The match was not exact, but the similarities were unmistakable. The slant, the loops, the spacing, all were consistent with my handwriting from 7 years earlier. My current signature had evolved. I wrote more quickly now, with less attention to form. But the earlier version, the one I had used during residency, aligned with the signature on the consent form. I told myself it was coincidence. I told myself the mother had simply written in a way that happened to resemble my earlier style. I told myself there was no reasonable explanation for my signature to appear on a form I had not signed. I put the documents away and went to bed. I did not sleep well. The boy returned for a follow-up visit 1 week later. The incision was healing without complication. There was no sign of infection or recurrence. His mother was pleased. I documented the visit and discharged him from my care. As the mother was leaving, I asked her casually if she remembered anything else about the surgeon who had spoken with her before the procedure. She paused in the doorway. She looked at me with a slight frown. She said she remembered now. She said it had been me. She said she was certain. She thanked me for my time and left. I stood in the exam room for several minutes after she was gone. I reviewed my memory of that morning. I had arrived at 6:30. I had met Monica at the nurse's station. I had gone to the preoperative bay at 6:52. I had not spoken with the mother before that moment. Yet she now remembered me as the surgeon who had obtained her consent 18 minutes before I arrived. I requested the security footage from the surgical center. The administrative assistant was reluctant but complied after I explained it was for quality assurance. The footage arrived 2 days later. I watched it alone in my office. The camera covered the preoperative area from a high angle. At 6:38, the mother and son entered the frame and were escorted to Bay 4. At 6:46, a figure in blue scrubs and a white coat approached the bay. The figure's back was to the camera. The figure spoke with the mother for approximately 4 minutes. At 6:50, the figure handed the mother a clipboard. She signed the form. The figure retrieved the clipboard and walked out of frame. I rewound the footage. I watched the figure's movements. The gait was deliberate. The posture was upright. The build was consistent with my own. I could not see the face. The camera angle did not allow it. I advanced the footage to 6:52. I entered the frame from the same direction the previous figure had exited. I approached Bay 4. I spoke with the mother. My posture, my gait, my gestures all matched the earlier figure. I filed a report with the surgical center's administration. I described the discrepancy, I provided the footage, I requested an investigation. The administrator, a man named Hugh, reviewed the materials and scheduled a meeting. He explained that the footage showed only one interaction, mine. He suggested I had forgotten the earlier conversation. He suggested fatigue or distraction. I told him I had not arrived at the center until 6:30. The timestamp on the footage showed the first interaction beginning at 6:46. Hugh pointed out that the timestamp was not always reliable. He said the system occasionally recorded incorrect times. He said it was a known issue. I asked him to check the system logs. He said he would. I never received a follow-up. I continued performing pediatric surgeries. I continued obtaining consent in person with clear documentation and witnessed signatures. I continued to review the forms carefully. But occasionally a form would appear in the chart before I had spoken with the parents. Occasionally the signature would resemble my own. Occasionally the parents would remember a conversation I did not recall having. I stopped requesting footage. I stopped filing reports. The surgeries proceeded without complication. The outcomes were consistently good. The families were satisfied. The records reconciled. Some consents are obtained before the conversation happens, signed by a version of yourself you do not yet recognize as familiar. Story 4. The neurosurgeon who operated without imaging. Neurosurgery is image-dependent. Every craniotomy begins with computed tomography, magnetic resonance imaging, and often angiography. We map the lesion in 3 dimensions. We mark the scalp based on those coordinates. We plan the approach to avoid eloquent cortex, critical vessels, and ventricular structures. Operating without imaging is not just unwise, it is indefensible. No neurosurgeon would proceed without visualization. I would not have believed anyone could, until it happened. The patient was a man in his mid-50s with progressively worsening headaches. His primary care physician had referred him after 2 months of failed conservative management. The working diagnosis was a space-occupying lesion, possibly a meningioma. I ordered a complete imaging workup, CT with contrast, MRI with and without gadolinium, and a CT angiogram to assess vascular involvement. The patient was scheduled for imaging on a Monday morning. The results would determine whether surgery was indicated. On Monday afternoon, my office received a call from the radiology department. The imaging had been delayed due to equipment malfunction. The MRI scanner had gone offline unexpectedly. The CT suite was backed up with trauma cases. The patient's scans would be rescheduled for Wednesday. I adjusted the surgical schedule accordingly. I informed the patient. He was frustrated but understanding. Wednesday arrived. I checked the imaging queue mid-morning. The patient's scans were still listed as pending. I called radiology. The technician, a woman named Jill, explained that the patient had not shown up for his appointment. I checked the electronic health record. The appointment had been confirmed the previous day. I called the patient. He did not answer. I left a message. I moved on to other cases. Thursday morning, I received a page from the operating room charge nurse, a man named Kyle. He informed me that my first case, a craniotomy for suspected meningioma, was ready. I told him there was a mistake. The case had been postponed pending imaging. Kyle insisted the patient was in the preoperative bay. I went down to check. The patient was there dressed in a surgical gown, IV in place. I approached him. I asked why he had not attended his imaging appointments. He looked confused. He said he had attended. He said the scans had been completed on Wednesday. I checked the chart on the mobile workstation. There were no imaging studies uploaded. I told him I could not proceed without the scans. He became agitated. He said he had been fasting since midnight. He said he had arranged time off work. He said the surgeon had told him everything was ready. I asked him which surgeon he had spoken with. He said me. He said I had called him Wednesday evening to confirm the surgery. I had not called him Wednesday evening. I had been at home reviewing journal articles. I told him there was a misunderstanding. He insisted there was not. He showed me his phone. The call log listed an incoming call at 7:32 Wednesday evening. The number was the hospital's main line. The call had lasted 4 minutes. I excused myself and went to the nurse's station. I asked Kyle if anyone else had spoken with the patient. Kyle checked the documentation. No one had. I called the radiology department and asked for Jill. She confirmed that the patient had not appeared for his scans. She had no record of completed imaging. I returned to the patient and explained the situation. He was angry now. He demanded to know why I was contradicting what I had told him the previous evening. I was about to cancel the case when the anesthesiologist arrived, a woman named Angela. She reviewed the chart on her tablet. She looked at me and said the imaging was complete. She turned the tablet toward me. On the screen were a full set of scans, CT, MRI, angiogram. The timestamps indicated they had been completed Wednesday at 2:15 in the afternoon. The images showed a well-defined extraaxial mass at the right frontal convexity, consistent with meningioma. The lesion was 4 centimeters in greatest dimension, compressing the frontal lobe but not invading it. The feeding vessels arose from the middle meningeal artery. The approach was straightforward. I asked Angela where she had accessed the images. She said they were uploaded to the patient's chart. I checked the chart on the workstation. The images were there. I looked at the timestamps again. Wednesday, 2:15 in the afternoon, the time the patient should have been in the scanner. I opened the image files. The quality was excellent. The sequences were complete. There was no indication of artifact or error. I called Jill again. I described the images. She pulled up the scanner logs. She said the right-sided MRI had been operational Wednesday afternoon, but it had been used exclusively for trauma cases. No outpatient scans had been performed. I asked her to check the CT logs. She did. Same result. The patient had not been scanned. I stood in the hallway, tablet in hand, staring at images that should not exist. Kyle approached and asked if we were proceeding. I looked at the images again. The anatomy was detailed. The lesion was clearly visible. The measurements were precise. I made a decision. I told Kyle we would proceed. The patient was brought into the operating room. Angela induced anesthesia without difficulty. I positioned the patient supine with the head turned left. I marked the scalp based on the imaging coordinates. I prepped and draped the field. I made a curvilinear incision and reflected the scalp flap. I created burr holes and turned a bone flap. I opened the dura. The lesion was exactly where the images predicted. The size, the location, the relationship to the surrounding cortex all matched. The tumor was firm, well circumscribed, and avascular on the surface. I debulked it internally using an ultrasonic aspirator. I dissected it away from the underlying brain with minimal retraction. The feeding vessels were easily controlled. I removed the mass in its entirety. The resection cavity was hemostatic. I closed the dura, replaced the bone flap, and closed the scalp in layers. The procedure lasted 3 hours and 46 minutes. The patient was extubated in the operating room. He followed commands immediately. His motor and sensory exams were intact. He was transferred to the intensive care unit for overnight observation. I dictated the operative note. I documented the imaging findings. I listed the coordinates, the measurements, and the approach. I sent the tumor specimen to pathology. The pathology report returned 2 days later. The diagnosis was meningioma, World Health Organization Grade 1. The margins were clear. The prognosis was excellent. I reviewed the report with the patient during his follow-up visit. He was recovering well. His headaches had resolved. He was grateful. He asked when he could return to work. I told him to wait 3 weeks. He thanked me and left. I returned to my office and accessed the imaging archive. I searched for the patient's scans. They were still there. I opened each sequence. I studied the anatomy. I compared the images to the intraoperative findings. They matched perfectly. I checked the metadata embedded in the image files. The scanner model was listed. The protocol parameters were listed. The timestamps were consistent with Wednesday at 2:15 in the afternoon. I copied the scanner serial number and called the radiology department. Jill answered. I provided the serial number. She checked the equipment database. She told me the scanner with that serial number had been decommissioned 8 months earlier. It had been replaced with a newer model. The old unit had been removed from the facility and sold to a hospital overseas. I asked her if there was any possibility the scans had been performed on the old unit before decommissioning. She said no. The patient had not been referred to our facility 8 months ago. He had been referred 6 weeks ago. I asked Jill if scans could be mislabeled or transferred from another patient. She said it was theoretically possible but highly unlikely. The images contained patient identifiers embedded in the metadata. I checked the identifiers. They matched the patient. I asked Jill if imaging could be generated retrospectively from surgical findings. She did not understand the question. Neither did I. I contacted the hospital's information technology department. I spoke with a technician named Brendan. I explained the situation. He accessed the imaging server logs. He confirmed that the scans had been uploaded to the patient's chart Wednesday at 2:23 in the afternoon. He confirmed that the upload originated from a workstation in the radiology department. He confirmed that the workstation had been logged into by Jill's credentials. I called Jill a third time. I asked if she had uploaded scans for the patient on Wednesday. She said no. She said she had not interacted with the patient's file that day. She said her workstation had been idle most of the afternoon. Brendan reviewed the activity logs. The workstation had been active. Files had been accessed, processed, and uploaded. The session had lasted 12 minutes. Jill had no explanation. I scheduled a meeting with the hospital's medical director, a surgeon named Paul. I brought the imaging, the operative note, the scanner logs, and the IT records. I explained the discrepancy. Paul reviewed the materials in silence. When he finished, he leaned back in his chair. He said the outcome was excellent. He said the patient was satisfied. He said the surgery had been successful. He asked what I wanted him to do. I told him I wanted to understand how I had operated using images that should not exist. Paul said he did not know. He said he would forward the matter to the Quality Assurance Committee. I never heard back. I continued performing craniotomies. I continued ordering imaging. I continued marking coordinates based on scans that appeared in the chart on schedule, complete and accurate. I stopped checking the scanner logs. I stopped questioning the timestamps. The images were always correct. The anatomy was always where the images indicated. The outcomes were always good. Some surgeries are planned not by the scans we order, but by the scans that arrive in time to justify the approach we were always going to take. Story 5. The cardiothoracic surgeon and the persistent bypass. Cardiopulmonary bypass is a temporary state. The heart-lung machine assumes the function of circulation while we operate on a motionless, bloodless heart. The duration is carefully monitored. Every minute on bypass increases risk. Coagulopathy, inflammation, organ dysfunction. We track the time in 15-minute increments. The perfusionist calls out the intervals. When the repair is complete, we restore native circulation. The machine is disconnected. The heart resumes its work. The bypass time is logged and closed. The case that defied this sequence was a mitral valve repair in a woman in her early 60s. She had chronic mitral regurgitation from a prolapsed posterior leaflet. Her symptoms had progressed despite medical management. I scheduled her for a minimally invasive approach: right thoracotomy, peripheral cannulation, robotic-assisted repair. The procedure was complex but routine for our team. We began at 8:23 in the morning. The anesthesiologist, a man named Derek, placed a double-lumen endotracheal tube and established venous access. I made a small incision in the right fourth intercostal space. The robotic ports were positioned. The perfusionist, a woman named Claire, cannulated the femoral artery and vein. We initiated bypass at 9:07. The heart arrested on cardioplegia. I inspected the mitral valve through the left atriotomy. The posterior leaflet showed classic prolapse of the P2 segment. I resected the redundant tissue, placed neocordy, and performed a sliding leaflet plasty. I tested the repair with saline injection. The coaptation was adequate. I placed an annuloplasty ring and closed the atriotomy. I de-aired the left heart and prepared to wean from bypass. Claire called out the bypass time: 1 hour and 42 minutes. I instructed her to begin rewarming. Derek resumed ventilation of the right lung. I removed the aortic cross-clamp. The heart began to fill. I watched the rhythm on the monitor. There was no organized activity. I waited. Still nothing. Derek administered atropine. I paced the heart transvenously. A rhythm appeared. Slow, irregular, insufficient. Claire maintained bypass. I reassessed the repair. There was no technical error. The valve was competent. The left atrium was adequately de-aired. I checked the coronary perfusion. There was no evidence of air embolism or thrombosis. Derek optimized the ventilator settings. I attempted to wean from bypass again. The heart would not sustain adequate pressure. Claire resumed full support. I decided to wait. Sometimes the myocardium requires additional time to recover from cardioplegia. Claire maintained bypass. I monitored the pressures, the oxygen saturation, the lactate levels. Everything remained stable. At 2 hours and 30 minutes of bypass time, I attempted another wean. The heart still would not support circulation. I began troubleshooting systematically. I assessed for tamponade, none. I checked for residual valve pathology, none. I evaluated right heart function, depressed but not absent. I administered inotropes. I placed an intra-aortic balloon pump. I attempted to wean from bypass again. The blood pressure dropped immediately. Claire resumed full support. At 3 hours and 15 minutes, I called for a ventricular assist device. The device was not immediately available. We would need to wait for the specialized team to arrive from another facility. Claire continued bypass. I informed the family of the situation. They were distraught but understanding. I returned to the operating room. Claire had been maintaining bypass for over 3 hours. This was well beyond the usual duration. I asked her how the patient was tolerating it. Claire checked her logs. The pressures were stable, the flows were adequate, the oxygen delivery was normal. There were no signs of coagulopathy or hemolysis. The machine was functioning perfectly. At 4 hours, the ventricular assist device team arrived. I prepared to transition the patient from bypass to mechanical support. As I was cannulating for the device, I noticed something unusual. The heart, which had been flaccid and unresponsive, began to contract. The rhythm on the monitor organized into a regular sinus pattern. The contractility improved visibly. I checked the inotrope infusions. They had not been changed. Derek had administered no additional medications. I asked Claire to attempt a wean. She gradually reduced the bypass flow. The blood pressure remained stable. She reduced further. The heart maintained output. At 4 hours and 28 minutes, we separated from bypass completely. The heart was supporting full circulation. The pressures were normal. The oxygen saturation was 100%. I was relieved but confused. There was no clear explanation for the sudden recovery. The heart had been unresponsive for over 3 hours, then had resumed function abruptly. I completed the closure and transferred the patient to the intensive care unit. She was extubated 6 hours later. Her neurological exam was intact. Her cardiac function was normal. She was discharged on the 5th postoperative day. I reviewed the perfusion records in my office later that week. Claire had documented the bypass time as 4 hours and 28 minutes. The flows, pressures, and oxygen delivery had remained stable throughout. There were no adverse events logged. The case appeared by all measures to be a prolonged but successful bypass run. I called Claire and asked her to meet me. I wanted to discuss the case. She arrived the following day. I asked her how the patient had tolerated such a long bypass time without complication. Claire said she had been surprised as well. She said the machine had performed flawlessly. She said the patient's physiology had remained stable. She said it was as though the bypass had been supporting more than just circulation. I asked her what she meant. She hesitated. She said the patient's metabolic parameters, lactate, pH, carbon dioxide, had not reflected the expected stress of prolonged bypass. She said it was as though the patient's tissues were not accumulating the usual metabolic debt. She said it was as though something else was maintaining homeostasis even while the heart was not functioning. I reviewed the laboratory values. Claire was correct. The lactate had remained low. The pH had remained normal. The base deficit had not widened. These findings were inconsistent with prolonged mechanical support. They suggested that the patient's circulation had remained adequate throughout, even though the heart had been arrested. I requested the transesophageal echocardiogram recordings. The images showed the mitral repair was competent. They also showed something I had not noticed during the case. During the period when the heart was not contracting, the left ventricle was not dilated. It was not overfilled. It appeared as though blood was still being ejected despite the absence of visible contractility. I reviewed the recordings with a cardiologist, a woman named Helen. She watched the images carefully. She agreed that the appearance was unusual. She said it looked as though the heart was maintaining output through a mechanism that was not visible on echocardiography. She said she had no explanation. I returned to Claire. I asked her if the bypass machine had recorded any anomalies during the case. She checked the machine's event log. There was one entry time-stamped at 3 hours and 51 minutes into the bypass run. The entry indicated a brief interruption in flow, less than 2 seconds. Claire said she had not noticed it during the case. She said the alarms had not sounded. She said the flows had resumed immediately. I asked her if an interruption of that duration could explain the patient's stable physiology. She said no. She said 2 seconds of interrupted flow would be insignificant. She said it would not account for the sustained homeostasis. I filed the case as a successful outcome with an unusually prolonged bypass time. I did not document the physiological inconsistencies. I did not pursue further investigation. The patient had recovered completely. There was no indication for additional inquiry. 3 months later, the patient returned for a follow-up echocardiogram. The mitral repair remained competent. Her cardiac function was normal. I asked her if she remembered anything unusual about the surgery. She said she did not. She said she remembered going to sleep and waking up in the intensive care unit. She said she felt well. I asked her if she had experienced any unusual sensations during her recovery. She thought for a moment. She said she had felt for several days after the surgery as though something was still assisting her heartbeat. She said she could not describe it precisely. She said it was as though her heart was not working alone. She said the sensation had faded gradually. She said she felt normal now. I thanked her and concluded the visit. I returned to my office and reviewed the perfusion records once more. The bypass time was documented as 4 hours and 28 minutes. The flows, pressures, and oxygen delivery had remained stable throughout. The patient had recovered without complication. The machine had performed flawlessly. But I could not stop thinking about the 2-second interruption. I could not stop thinking about the stable physiology. I could not stop thinking about the patient's sensation that something was still assisting her heart. Some bypass runs end not when the machine is disconnected, but when whatever else was maintaining circulation decides it is no longer needed. Story 6. The general surgeon listed as attending. I was assigned as secondary attending for the overnight general surgery service. The role was supervisory. I was available by phone for consultation. I reviewed cases remotely and provided guidance to the on-call residents. I did not routinely scrub into cases unless the situation was complex or the resident requested assistance. The system was efficient. It allowed the teaching service to function independently while ensuring oversight. The discrepancy appeared on a Tuesday morning. I arrived at the hospital at 7:15 to review the previous night's operative cases. The resident, a 4th-year named Callahan, handed me the log. There were 3 cases: an appendectomy, a cholecystectomy, and an exploratory laparotomy for bowel obstruction. All had been completed without complication. Callahan briefed me on each case. I signed the log and prepared to move on to my scheduled cases. At 7:45, I received a page from the medical records department. A clerk named Beth asked me to verify my operative note from the previous night. I told her there was a mistake. I had not operated the previous night. She insisted my name was listed as the attending surgeon for the exploratory laparotomy. I asked her to forward the note. She did. I opened the document on my phone. The case was a 67-year-old man with small bowel obstruction. The operative note described a midline laparotomy, lysis of adhesions, and resection of a segment of ischemic bowel with primary anastomosis. The attending surgeon was listed as me. The resident was listed as Callahan. The operative time was 2 hours and 33 minutes. The procedure was documented in precise detail. The incision, the exploration, the identification of the obstruction, the resection technique, the anastomosis method, the closure. The note was thorough and professional. It was written in a style consistent with my own dictation habits. I called Callahan. I asked him who had scrubbed into the laparotomy. He said he had operated alone. He said I had been available by phone but had not come in. He said the case had been straightforward. I asked him who had dictated the operative note. He said I had. He said I had called him at 3:20 in the morning to review the case and had dictated the note remotely based on his description. I told him I had not called him at 3:20. I had been asleep at home. Callahan was silent for a moment. Then he said he remembered the call clearly. He said we had discussed the adhesiolysis technique. He said I had asked specific questions about the bowel viability. He said I had provided guidance on the anastomosis. He said the call had lasted approximately 12 minutes. I checked my phone. There was no record of an outgoing call at 3:20 in the morning. I went to the medical records department and spoke with Beth. She pulled up the note on her computer. She showed me the metadata. The note had been dictated at 3:34 in the morning. The dictation had been logged under my credentials. The audio file was available. I asked her to play it. The voice was mine. The phrasing, the cadence, the terminology, all were consistent with my dictation style. I described the case exactly as it had been documented in the note. I spoke calmly and methodically, detailing the findings and the technique. The dictation lasted 4 minutes and 17 seconds. I listened to it twice. I could not identify any discrepancy between the voice and my own. I asked Beth if the audio file could have been fabricated or transferred from another case. She said the system did not allow that. Each dictation was captured in real time and linked to the patient's chart. She said there was no mechanism for retroactive editing. I asked her to check the login records. She did. My credentials had been used to access the dictation system at 3:34 in the morning from a workstation in the surgical intensive care unit. I went to the intensive care unit and asked the charge nurse, a man named Vincent, if anyone had used the workstation at that time. He checked the access log. No one had documented using the workstation during that hour. The unit had been quiet. The staff had been at the bedside. I asked if the workstation had been left unlocked. Vincent said it was possible, but unlikely. The workstations logged out automatically after 10 minutes of inactivity. I reviewed the patient's chart. The exploratory laparotomy had been performed as described. The post-operative course was uncomplicated. The patient was recovering well. I went to see him. He was awake and comfortable. I introduced myself as his surgeon. He thanked me. He said the operation had gone well. I asked him if he remembered speaking with me before the surgery. He said he did not. He said he had been in significant pain and did not recall much from that night. I returned to my office and requested the operative footage. The recording was available within an hour. I watched it alone. The timestamp began at 1:08 in the morning. Callahan entered the operating room and began the prep. The anesthesiologist, a woman named Iris, was visible at the head of the table. The scrub nurse, a man named Todd, prepared the instruments. The case proceeded as documented in the operative note. At 1:23, Callahan made the midline incision. He entered the abdomen and began the exploration. He identified dense adhesions in the right lower quadrant. He lysed them carefully. At 1:51, he identified a segment of distal ileum that was dusky and non-viable. He resected the segment. He prepared the bowel ends for anastomosis. At 1:59, a second figure entered the operating room. The figure was gowned and gloved. The figure stood opposite Callahan. The figure's face was obscured by a surgical mask and loops. The figure assisted with the anastomosis. The hands moved with precision, placing sutures, tying knots, checking the integrity of the repair. Callahan did not acknowledge the figure. He continued working as though the assistance was expected. The anastomosis was completed at 2:14. The second figure stepped back. Callahan irrigated the abdomen and began the closure. The second figure left the operating room at 2:21. The remainder of the case proceeded without incident. Callahan closed the fascia and skin. The patient was extubated and transferred to the intensive care unit. I paused the video. I rewound to the moment the second figure entered. I studied the figure's build, posture, and movements. The gestures were familiar. The hand positioning was familiar. The suturing technique was familiar. I compared the figure's movements to my own technique, which I had reviewed in previous operative recordings. The match was precise. I called Callahan again. I asked him who had assisted with the anastomosis. He paused. He said no one had assisted. He said he had performed the anastomosis independently. I told him the footage showed a second surgeon. He was silent. Then he said he did not remember a second surgeon. He said he remembered only performing the case alone. I asked him if it was possible he had forgotten. He said he did not think so, but he could not be certain. I brought the footage to the surgical director, a man named Ed. I explained the situation. Ed watched the footage. He did not speak until it was finished. Then he asked me if I had been in the hospital that night. I told him I had not. He asked if I had any explanation for the figure in the video. I did not. Ed said he would review the matter with the credentialing committee. He said there were protocols for addressing unscheduled participation in surgical cases. He said he would follow up with me. 2 weeks passed. I did not hear from him. I sent a follow-up email. He responded briefly, saying the matter had been reviewed and no action was required. He did not provide further explanation. I continued my role as secondary attending for the overnight service. I continued reviewing cases remotely. I continued signing operative logs. Occasionally, a case would appear in the log that I did not remember reviewing. Occasionally, an operative note would be dictated in my voice for a procedure I did not recall discussing. Occasionally, the footage would show a figure assisting the resident, moving with techniques that matched my own. I stopped requesting footage. I stopped questioning the operative logs. The cases were completed successfully. The outcomes were good. The residents were learning. The system functioned smoothly. Some attending surgeons supervise from a distance. Others appear in the operating room without being summoned, performing techniques that feel learned rather than instructed, leaving before anyone remembers to ask why they were there.